see, I also got a new computer at work this week, and you guys know how IT things happen. So let me see. Okay, here we go. Thank you for the nice introduction. Vision is something that I've been really interested in the course of my career because it's so impactful for our patients after they have a neurological event, especially stroke or brain injury. And so I've been working at it for a lot of years and have really been trying to help as much as I can with my scope of knowledge, kind of push the field and help others get educated. And so I hope that you'll feel good about what you're learning here today. Our big objectives are to talk about some common causes of double vision after stroke. I'm going to give just a little bit of demonstration about some screening options, and then really to talk about compensatory and remedial opportunities that are available to us in terms of helping people improve and hopefully get rid of their double vision after a stroke. As most of you know, anybody who's in the field of research or have been around in the field a while, we just don't have a lot of solid, valid information about vision and stroke and brain injury. It's starting to come a little bit more, and I think there's a lot of opportunities for us to continue to add to the body of literature for those of us who are working in the field. But there's a study that I found by Fiona Rowe that was written in 2010, and all the references are at the end of these slides. But she had a study that estimated that I think they looked at 200 or so patients, or maybe a little bit lower, but 16.5% of those stroke survivors had some incidence of double vision. And in general, it's been estimated as high as 80, and I think I've read 90% in the past of people who have some sort of acquired brain injury have some sort of vision deficit. Vision problems negatively impact ADL performance. It can be a big barrier to reading, computing, mobility activities. And those are all the activities that patients are working on while they're in rehabilitation. So I think it's really important for us to continue to push early intervention in the field, especially if a person's in a rehab program. Because imagine if you're trying to relearn how to brush your teeth or walk or do, read or think while you're having double vision. That can be really overstimulating, and I think it makes it doesn't help outcomes if people are really trying to, suffer through a rehab program while they're having double vision. I think too, in the rehab environment, it's therapeutically rich, and in our country, some patients get only about 2 weeks on average to be in rehab, so we want to maximize the time that they have there. I also think it's an important time as a person is recovering to try to prevent maladaptive behavior, and double vision can really cause people to have postural changes, or it can influence muscle tone, especially in the neck and trunk. And so if we help people be comfortable at the very least early, we can help prevent maladaptive behaviors, and then we can help at least educate and build awareness for our patients as they go along their rehabilitation trajectory. Double vision, when we think about that in rehab, it is an eye teaming issue. So it is a result of something happening with the eyes not working together well. And the two main contributors of having an eye teaming issue after a stroke or brain injury is a misalignment. And I'm going to talk about each of these a little bit more, but you can have a physical misalignment of the eyes from their neurological injury, or you can have a general spatial perception or coordination issue that doesn't involve a physical turn of the eye, but can cause a person to have double vision. With alignment, brainstem stroke and cerebellar stroke are most likely to result in an alignment issue because of the proximity to the nuclei of the cranial nerves, specifically 3, 4, and 6. You can have an internuclear, so you can have a palsy to the cranial nerves, which result in an eye turn. You can have an internuclear ophthalmoplegia, which involves the communication or the fibers between the nuclei of the cranial nerves that can result in a little less straightforward types of misalignment, as you would find in a straight cranial nerve 3, 4, or 6. And you can also have a skew deviation, which is a vertical misalignment, and we see this a lot in cerebellar type injuries, where it's a vertical misalignment that's not attributed to a 3, 4, or 6. And that diagnostically, it shows up more when a person is sitting than laying down. And when we say there's a misalignment, the term that's used is strabismus or atropia, which means a physical turn of the eye. And so the eye can be described as turning out, in, up, or down. And you see the terms exo there, which relates to out, eso to in, hyper and hypopropia. So that's how we describe misalignment. Other sources of misalignment that can happen, if there's an orbital fracture involved, we see this a lot more in traumatic brain injury versus stroke, but if there's a change in the orbit, the eye can be sitting differently in the orbit, and that can affect alignment. Again, if there's a fracture or something going on around the orbital bone, a muscle can get entrapped and just stuck in there, and that results in misalignment because the eye then can't take its full range of motion. And then people can have an eye turn from childhood or amblyopia that can also affect alignment of the eyes. With spatial perception and coordination issues that cause double vision, typically those involve more of the cortical areas and not so much in the nucleus of the cranial nerves. But a lot of times we see people get decompensation of a prior resting posture. So people, a lot of us have a tendency to rest our eyes out more or in more than right exactly at our focal point, but our brains are really good at compensating for that. I myself have an inward resting posture, and functionally how that shows up for me is getting a little bit double when I get tired and my brain just can't compensate anymore, or if I have too much fun at a party or happy hour, let's say, or people tease me because when I park my car, the rear end of the car is a lot of times sticking out farther than the others, because perceptually I'm perceiving my focal point of where the appropriate parking distance is in a little bit more. And so the definition of that, the general resting posture of the eyes, is called aphoria. And so you can also have an exophoria, which is a general outward resting of the eyes, and esophoria, inward, or hyper or hypophoria, where there's not a physical turn of the eye. They line up for all intents and purposes. But when they're working together, they're looking a little too far out, a little too far in, or a little off. And then also, when we just talk about near point convergence or accommodation, people can get double vision if they're sluggish in those areas, but also don't have a physical turn of the eye. Other times you might see double vision is if a person has a really bad refractive error. They can perceive double, and usually if it's from a refractive error or a cataract, you can get double vision. Usually we see that with them having double vision in one eye. So if they close one of their eyes, usually with double vision, if a person closes one eye, it alleviates it. But in the case of a refractive error, sometimes if they close one eye, they still have double vision, and usually that tips us off that they maybe need to get their visual acuity checked or other things like that. When we screen for eye teaming, looking at alignment is a little bit different than looking at the spatial perception or coordination, the sources of double vision. So when you hear a patient complain of double vision, it's important to look at their alignment, and it's also important to look at their spatial perception coordination. That requires some different screening methods. And so the most helpful things, just from a pure screen, and there are a lot more diagnostic tests that ophthalmologists or optometrists can do, but for general in rehab screening, pursuit test really helps us know if there's an issue in the range of motion of either of the eye. Hirschberg test and cover test help us look at the alignment. I'm going to show you some videos of those. And then for spatial perception coordination, we look at near point convergence and doing an alternate cover test. So if a person has an alignment problem, they're not going to be able to do well. They're also going to have problems with near point convergence and alternate cover test. But if a person doesn't have any issues in alignment and they're complaining of double vision, so if they pass, the pursuit test looks good, range of motion looks good, Hirschberg cover test, everything looks good. The near point convergence and alternate cover test can let us know what else might be going on that's contributing to the double vision. And just to pause for a second, I'm not sure you know, if all of your centers regularly screen vision, but here's just a list of areas that I feel are really important to include in any kind of vision screen that kind of do a comprehensive job of picking up on some of the more important aspects of vision and kind of help pick up all the red flags. There was a systematic review that was also published by Rowe and her team over in the UK recently about screening methods, and you know, they looked at a lot of screenings, vision screenings that are out there or that are published in terms of a more formal battery, but they found that there really isn't one battery out there that really gets it comprehensively, and I agree. From a visual and perceptual standpoint, to kind of get it all, you know, I think we have some ways to grow. The most comprehensive that I've seen out there is the by VABA, the Brain Injury Visual Assessment Battery for adults, which is Mary Warren's test. But I think this is an area that we can continue to push the field, I think, just so that at the very least, even if you work in a center that doesn't do a lot in terms of treating double vision or other visual issues, I think sometimes, you know, if we're identifying these things, I think it really helps drive treatment, and at the very least can help a patient advocate for themselves once they get out of our systems of care. So today we're going to focus just on the alignment piece because we're talking about double vision related to the cranial nerves. But those right there, you have a list in front of you of the areas that I think would be important to cover. And I always recommend, I think it's helpful if centers are newer with vision screening to just start doing them on all the patients and collect them. And that's a nice resource to be able to go back and say, you know, over the last year we screened so and so many patients and this many have had this or that issue. I've had a lot of people who have taught in the past have success in their facilities by kind of collecting those and being able to use those as advocacy for earlier intervention for the patients as well. The first test that is helpful for picking up an alignment issue is a pursuit test. And again, I apologize if the audio isn't going to come right to hear the video. By chance, I'm going to ask, can you guys hear the video?
No.
Okay.
No.
Drat. So when you do a pursuit test, it's important to just get all of the oculomotor muscles, and you can do that by doing an H pattern or a star pattern. So kind of going horizontally, vertically, and getting all the diagonals, or going across and going vertically at the end range to just catch all of the muscles. So in this particular case, the patient doesn't have any range of motion limitations with his eyes. This is just to kind of show how a pursuit test could go. And I will say there's many ways, you know, there's not one, you know, gold standard way for a lot of these screening methods. You know, the main goal of a screening is to find out if there are issues happening, and you know, you want to be able to do it in a way that helps you know if there are issues happening so you can help formulate a plan of care. Here is a video of the Hirschberg test. So again, in pursuits, we were looking for if there are any range of motion limitations that might be contributing to double vision. And the Hirschberg test lets us get a good picture of how their eyes are aligned at rest. and it's a super simple test. It involves you just shining a light at the patient's nose, at the bridge of their nose, and having them look at the light about 16 to 18 inches away from their nose. And then you look in their eyes to see, you look at the reflection of the light in their pupils to see if the reflection itself is aligned. So in this gentleman's case, he's pretty aligned. There's not any major issues happening with his alignment. But if you see in this picture, and you can tell with the naked eye in this case that there's an obvious misalignment, but if you can see where the light is reflecting over here, it's reflecting in the center of the pupil on his left eye, and it's on the outside of the pupil on his right eye, which indicates an inward eye turn. And so the Hirschberg test, this is very obvious, but sometimes that can help us just tell in a little more subtle cases. And then here's just a little resource of what the Hirschberg test would look like with an outward, inward, upward, and downward eye turn. And I'm going to figure out the best way to share this presentation with all of you so you can have access to it. And then hopefully you'll be able to watch the videos on your own with the sound, which would be helpful. The third screening tool that is helpful is the cover test. And the cover test involves a person fixating on an object, and then you cover one eye, and then you watch the other eye to see if it has to make an adjustment to get back on the target. So you cover each eye, and you see if the other eye has to make an adjustment to align with the target. If the person has to align, to move their eye to align with the target, you assume that their eye is turned, and depending on which direction they have to adjust, it tells you which way the eye is turning. So let me see, I tried to put a YouTube video on this. Shoot. Oh, here it comes. So here's a cover test being done on abnormal with an eye misalignment. And when I send you this presentation, you can look at the other videos. But here you see when you cover one eye, it's aligned, but then the other eye has to jump out to fixate on the target. And actually, I'm going to start it back here. This is let's see if it'll go. Or there's a gentleman right over here that has, here we go. So if you look, when you cover one eye, that eye is aligned, and then the other eye has to make a big inward and downward adjustment to look at the target. So that's just another way that you can, here's a third case. You see her left eye is aligned, but when they cover her right eye, or her left eye, the right eye has to go out to adjust to the target. So you would assume she has a right inward eye turn, and you can kind of see that with the naked eye. Okay. All right. So with the cranial nerves, I just put a simple definition about what are the roles of each of the cranial nerves. And here is a picture of a gentleman with cranial nerve 3 palsy. And as you see over here, the oculomotor nerve, or cranial nerve 3, helps open the eyelid, it helps move the eye up and down, and also helps adduct the eye or bring the eye inward towards the nose. And so when you see a third nerve palsy, a person can have a drooped lid. They often have an outward and slightly downward resting posture of the eye. Their pupil will be better because cranial nerve 3 also involves pupillary response. And a lot of times they'll complain of difficulty focusing with that eye alone because of the sluggish pupil. And then they'll often complain when the lid is open, they will complain of double vision. But when the lid is closed, they don't have double vision because they have a natural patch with their eyelid. And then posturally, when this is happening, a person can sometimes get their eyes aligned if they turn their head towards the unaffected eye. But then they develop a postural change, where they're keeping their head turned horizontally off to the side instead of in midline. And we know that that affects all sorts of things with balance and posture because of all of the balance and posture receptors that are in the neck. So there's cranial nerve 3 palsy. Here's a picture of a gentleman with cranial nerve 4 palsy. And the big hallmark of cranial nerve palsy is a person who complains of double vision when they're looking down, because with cranial nerve palsy, when a person is looking down, the impaired eye turns outward when they go down. And so as you see in the picture, this gentleman has a head tilt to compensate for the vertical misalignment, and his right eye is kind of resting up and out compared to the left. But when he looks down, you see that right eye floating out. And these folks have a really hard time just doing any ADLs that involve downward gaze, like reading or walking, going up the stairs or down curbs. And you'll often see the head tilt to compensate, because when they tilt their head, that helps get things in alignment. And then also they might cover or close an eye to get rid of their double vision. And then cranial nerve 6 palsy involves an inward eye turn. And so it's when the lateral rectus is not engaged and allows the eye to float and rest in towards the nose. And what you see with a cranial nerve 6 palsy, a person won't be able to abduct or move their eye outward. Again, they'll complain of double vision and often cover or close an eye, and then they will turn their head towards in the direction of the affected eye to get things lined up. And so a person, again, it's the same issue with cranial nerve 3 and actually cranial nerve 4. If a person's having to make these postural adjustments to get single with their vision and they go around all day having that, does that cause secondary complications like pain or impaired midline awareness because they're not able to keep their head in the middle? So with any vision screening in rehab, I think it's important to remember that it's not diagnostic. We need our optometric and ophthalmic or ophthalmologic colleagues to be able to do the diagnosing for us, and physiatry can often help with that. So it's important that we don't go into a screening diagnosing things, but we can pick up on things that would require further testing, require a referral to an optometrist or ophthalmologist, and would help guide our treatment. So I think the most important thing, especially with screening for double vision, is that it just helps us know, do we need to get a person to optometry or ophthalmology to help give us further insight into what's going on with this person's vision. And I think it can be really helpful to have a relationship with an optometrist or neuro-ophthalmologist in the inpatient rehab setting to help get some of these things going early. And we'll talk about this a little bit more with treatment, about how important it is to kind of have things, have an eye doctor involved. The way we do it here at Craig, we have an optometrist who has special interest in neurorehabilitation. He comes to our clinic once a week in the afternoons, and he holds a clinic where we bring patients who have had abnormalities on their screening. So every patient gets a screening, and then patients who have issues get to come and have a pretty quick evaluation, but the occupational therapist comes and the eye doctor is there and the patient, and so they can further evaluate the patient and kind of make a game plan for how we're going to help the patient with these issues. And it was really interesting, when I was doing my master's degree program, I did a thesis about vision care collaborations, and I'm feeling guilty that I didn't publish it was like 10 years ago. So I'm thinking about doing a repeat study to see if anything's changed in the field. But I sent out a survey to all sorts of neuro rehab hospitals to find out, how are they having these relationships? Do they have a relationship with an eye doctor? Do they collaborate? What's the nature of the collaboration? And it was interesting. Most people who had an eye doctor said that they had a collaborative relationship, but then with further assessment, like further explanation, the collaboration involved the doctor seeing the patient independently and then just sending a list of orders. And while I think that can be helpful, obviously, to just, it's really important for us to get the diagnosis and get things going. But I think it was interesting to see that that was what collaboration looks like. And I think we can make a lot more magic with the patients when we get to have dialogue together as professionals, if we have that luxury to be able to do that. So maybe I'll repeat that study and see if things are going any different in the field and get that information going. When we think about prioritizing vision interventions in general with a recovering brain, it's important to think first about how can we get this person comfortable and attending with their vision. If you think about any kind of vision injury, even external or eye health issue, if they have double vision, if they have anything that's really causing them to not be able to attend or to be very uncomfortable or overstimulated, the first line of defense is to try to get a person to a place where they are comfortable. That might involve, we'll talk about how this plays in with double vision, but sometimes even if they had an accident or they had a stroke and they don't have their glasses in the hospital and they need them to be able to see, that can be really difficult for them to do things. So it'd be important as quick as possible to help people be as comfortable as possible with their vision. Once a person is comfortable, or we kind of get on a path of getting them comfortable, then working on relearning is possible. To help them remediate any of the visual issues that they're having, and then educating so that they can they can know about their visual issues and be able to advocate for themselves. And all this whole time, being as collaborative as possible with OT, PT, speech, physiatry, optometry, ophthalmology, to help get a good care plan, and then being as patient-centered as possible. We might have big goals for the patient in certain areas, but that might not be as important to them. So keeping that in mind is also helpful. So in the case of double vision, and especially related to alignment, but this also helps for spatial perceptual coordination stuff, the simple thing we can do to help a person be comfortable and attend is to do some sort of patching. And a lot of times optometrists or ophthalmologists will recommend patching, and patching helps take away one of the double images. So you can do full patching, partial patching, and at this point it would be helpful, I think, to talk a little bit about using a black patch versus what we call a spot patch or a tape patch. Or a partial patch. So you see in this picture, there's a gentleman there who has some transport tape, which is just nursing tape that adds some blur. It's translucent, so it transmits light, but it doesn't allow a person to see clearly. So sometimes that's all a person needs to be able to take away the double image. And the beauty of using a tape patch is that a person still gets to use their peripheral vision. Using a black patch takes away the light from the eye and also essentially creates a field cut. We're working on a study here at Craig. I'm trying to get one going about spot patching and the power of using a translucent patch over a black patch. And a few weeks ago, we put me in a visual field machine and wore a black patch, and I just took a simple visual fields test. And then we put me in a translucent patch. And in the translucent patch, I was almost, I would say I was like 80 to 90% accurate with with having a full visual field, and with the black patch, it looked as though, you know, I only had one eye that was giving me vision. So I think this makes a big difference in terms of mobility. And then there are some other ways. If a person doesn't like the looks of a tape patch, sometimes you can use clear nail polish on the lens. We just keep a stock at Craig of some, where I work, of some plain glasses from Amazon. You can order them. They're like $1.50 from Amazon. I think you look under nerd glasses. And so we just keep a stock here that we can loan the patients. And then you can also use clear nail polish and kind of model it with put your fingerprint in it, and that creates enough blur. Another center that I visited recently uses Scotch tape, and then there are fancy foils that a lot of optometrists and ophthalmology offices have that have really specific opacities to them that also can be used to create a spot patch. And then I think I have some pictures here. So here's just a simple spot patch covering the central part of this person's vision. So the idea with the spot patch is to put it just over where the eye is pointed. So then you can use, it just covers the double image. This gentleman's eye was pointed down and out. So we had the tape just down and out over where his eye was pointed. And then this young lady, because she's young and growing, she didn't like wearing a tape patch. And so the eye doctor that we work with, Dr. Politzer, ordered her a spot patch contact lens. And so this contact lens had a black spot on it that just covered her pupil, and that allowed her to not have a double image and cosmetically not have to wear glasses. And then here is an example of binasal patching. Binasal patches are great for any patient who's experiencing visual motion hypersensitivity in general. I found them really helpful with post-concussive patients and mild brain injury. But the cool thing about the binasal patches is if a person does have maybe an esotropia or an exotropia, you can wear the binasals and the person can turn their head left or right to get their vision in the patch. And this is probably more helpful for someone who has phoria, like an exo or esophoria, so not a huge misalignment. You can see if the eye is turned way out, this patching method won't help, but it's a more subtle way to give a person a way to take away their double vision, and sometimes can help too with visual motion hypersensitivity, help a person feel more grounded. The other thing that we can use to help a person get more comfortable is what we call a Fresnel prism. And that is a stick-on prism that basically shifts images out to where the eye is pointed. So then the person can perceive single vision instead of double vision. So this gentleman is wearing one over his right eye. And I think Fresnel prisms recently became very famous when Hillary Clinton had to wear one on her glasses to help her get her alignment better as she was recovering from her neurological incident. But here's a video. You guys aren't going to be able to hear it, and I apologize for that, but I want you to just watch this guy, see if you can get a sense of his reading. He has double vision, and he's trying to read this book. And you see him closing his eye. And think about how much effort that takes to have to constantly close an eye to get something like that done. So you can see in this video, he's more fluid with his reading if you kind of watch his lips, but also he's not having to close his eye over and over. The other thing that often comes up with misalignment or double vision from misalignment is the opportunity to have an ophthalmologic surgery to realign the eye. And at Craig, our care team recommends waiting a year prior to alignment surgery, and then we work really hard to help people improve their proprioceptive awareness and spatial awareness of the eye prior to surgery, so that the eye is already kind of, when an eye isn't resting in its normal posture, it loses its proprioceptive sense and has a harder time with spatial awareness. So we want to try to get the eye to have as good a proprioceptive awareness, spatial awareness as it can, because we find that it helps the rehab after the surgery be a little bit better, because the eye is more aware of what's going on. So I'm going to take a quick second to just pause and see if anybody has any major questions, because what I really want to talk about is some of the treatment ideas or thoughts. But do you have any questions or thoughts at this point?
Amy, this is Cecil. Came to mind. Are there any negative effects of patching on patients without a full vision screen?
The question is there any negatives to patching before you've done like a full evaluation from the eye doctor?
Correct.
No. What I think it does is helps them be more comfortable in their rehab and able to do a little bit more in their rehab. And so, if a person, it's widely known that a patch in general helps a person not have double vision, and whether that's a full black patch or a tape patch, it's still a patch. So, I think that's well within our scope to help a person compensate, because otherwise they're going to be patching it themselves by closing their eye all the time. And that's exhausting. It takes a lot of effort. And
Correct.
So it's one way we can just help them be more comfortable.
Thanks.
Okay, let's talk about treatment, and then we'll have a little bit of time, hopefully, at the end. Before I talk about any specific techniques, I want to just give you guys some foundational paradigm type thoughts about how to kind of look at helping a person with eye misalignment improve their vision. The first thing that comes up a lot is vision. Are we doing vision therapy, and is that outside of our scope? And vision therapy is often like quote unquote formal vision therapy happens a lot in optometrists or ophthalmologic offices, and traditionally was related to kids with learning disabilities, and has a strong focus on skills like oculomotor skills, convergence, really helping a person improve these. And so vision therapy can be helpful for the neuro patients. The hard thing is that our neuro patients have things going on in more systems than vision, and really the vision impacts posture and mobility, impacts vestibular imbalance, and it can take a person a lot of time, sometimes through their inpatient and outpatient rehab programs, to get to formal vision therapy. And we're finding at Craig, if we can help people early on through doing neurovision interventions, it keeps them, helps things resolve even before they leave the rehab system, and then they don't have to spend the time and money in formal vision therapy as they leave. But I do feel like formal vision therapy is important and can be helpful as a piece of a patient's vision program. So I want to be clear about that. But in our scope as rehab professionals is neuromuscular reeducation. There are muscles in the eyes, and those muscles have proprioceptive receptors, and just like an arm or a leg or a trunk or anything like that. So as we're helping a person relearn throughout their body, we can also help the eyes relearn. Sensory integration is well within our scope in terms of working on balance and or a person's ability to process their senses. And then therapeutic exercise is something also that we do all the time with our patients to help them improve their strength. So I think we can help patients with their eye misalignments here, within their rehab program. So that's one foundational thought. Another foundational thought is about neuroplasticity and the principles, put forth by Klein and Jones back in 2008. Especially use it or lose it, use it and improve it. And I think salience is really important, kind of turning up the signal to help a person be able to make a change. And so repetition intensity as well. All of these principles are helpful. And if you haven't read this article, it's a great one to just kind of keep in your drawer and remind yourself every now and then as you're helping people relearn skills after brain injury. Also, one of my favorite quotes about interdisciplinary rehab in general is that our greatest challenge as a team is to know enough about the client, each other's profession, and the rehab process in general to give better feedback to each other and the client. But if you apply this particular statement to sensorimotor rehab, you could say that one challenge in sensorimotor rehabilitation, or neuromuscular rehabilitation as we call it, is to know enough about the sensory systems, how they communicate with other, and the impact they have on motor output and the related rehab techniques to give better feedback to the brain for learning. So what we're really talking about is helping give afferent information to help the brain, or give information or input that helps the brain make good sense of it and have the appropriate motor output or afferent output. When we think about vision rehab, vision interacts with all of our other senses, and we all get a sensory knowledge deficit in elementary school when they teach us that there are only 5 senses, when really 2 of our more primal senses, kinesthesia or body sense, and balance or vestibular sense, are really big players and have high connections with the visual system. And so if we are weak in our visual system, or we need to send, if vision isn't getting a great signal, for example, if an eye needs to be able to turn in more and it's not turning in, and maybe that muscle doesn't have great proprioception or awareness of where it is, we can use all of our other senses to help up that signal or up that input. Either by giving an auditory cue to help increase where we want a person to look, to use the vestibular system to help give a sense of where a person needs to look, to give a proprioceptive cue. We can use touch. We can use smell, sometimes smell and taste. Sour is a big one for improving or increasing convergence, getting people to come in closer. Which is kind of interesting, but we can use or leverage the other senses. And I think that's really important, and to use a multisensory approach to give better feedback to the brain. Another really important paradigm is to think about the primary visual systems. So our vision, in our visual process, we use 2 main visual systems. One is for is called our central vision, or is our system that helps us get detail about information to really glean a lot of higher cognitive type of visual information. But we also use our peripheral vision, which is our more primal sense. And in this illustration, this kind of shows how the central visual system, peripheral visual system work together in the task of driving, where you see a person, you pick up more detailed information. Perhaps you're going to read the license plate on that car, or you can tell that it's a Cadillac. But our peripheral vision is what allows us to judge space and time, and really gives us our sense of spatial information. And so the peripheral visual system helps us answer the question, where am I? Or where is it, or where am I in relation to it? So if you're thinking about the whole forest through the trees illustration, our peripheral vision gives us the forest. It helps us detect the bigger picture. It helps us detect movement. This is the part of our vision that helps us with balance, posture, and movement. It gives us verticality. It helps us get accurate visual motor integration. It gives us our visual flow. And that is what, it happens very subconsciously, so we don't have to think about it a lot. And if we are kind of stable in our peripheral vision, we can use our central visual system well to answer the question, what is it? So the question that follows, where is it or where am I? The question that follows is, what is it that I'm looking at and what do I need to know about it? And so central vision, visual process helps us with recognition, comparison, visual thinking skills, helps us discern different features. And so when we think about rehab, it's important to think about how the peripheral visual system is driving the central visual system. And we can use that peripheral visual system to help people feel a lot more grounded and to kind of leverage how their eyes are moving. Another foundational thought is Mary Warren's visual hierarchy. Mary Warren has been a pioneer OT in addressing vision and neurological rehabilitation. And going down at the base, it's important for us to understand what's going on with ocular motor control, visual fields, and visual acuity. But I kind of think there's one piece, because of that really important peripheral visual system, I think a person's spatial orientation is even more important beneath all of that to help a person develop appropriate ocular motor control, to understand their visual fields, and to get their visual acuity. So spatial orientation is a lot of times where I recommend people start in terms of visual treatment. Is, are they aligned on their midline? Do they have this sense of where am I and where is it? And I think that can be helpful in treatment. And then a lot of times, if the brain doesn't like to have double vision, obviously, and so sometimes a person will have double vision for a while, but then they'll stop having double vision even though they have a really noticeable eye turn. And that's called is suppression, is that the brain just learns how to turn off that other image. And so our rule here at Craig, that if a person is suppressing, their brain is adapted the way it wants to adapt, and we don't go opening up a big can of worms trying to get them to turn that eye back on. It is possible to give a person permanent double vision. If they've suppressed and you really work hard to turn it back on, it can be harder to get them to suppress in the future. And so then, they have to permanently compensate for that or work really hard at remediating it. And I do think it does take some cognitive effort to get things going. And so our general rule is, if it isn't broke, don't fix it. Also, if a person has a visual field cut, so in this instance, this patient has a left visual field cut, and she has a left cranial nerve 3 palsy, but because her left eye is pointed out, she is able to get more of a visual field. And if you work really hard to get that eye to come back in midline, then you make the field cut even more dramatic. So there are times where it can be helpful. A person's misalignment can work to their advantage. And if they can learn to suppress the central image and not have double, that can actually help them over time, because their visual field will still be processing and they would get a wider field for more safe mobility. So a general approach for helping treat alignment problems with double vision would be to start with spatial orientation. And this could happen within a session or across a period of sessions. But to start with a person's general body proprioceptive awareness of where they are in space, and to help the eye know where it is in space, to work on positioning and posture, and then to start working eye movement. So working on range of motion, and then helping the spatial orientation as well with visual motor activities, to start giving the eye and the body more information about where is it. And as a person develops better proprioceptive awareness, improved ocular motility, better visual motor awareness, then starting working on convergence, accommodation, and fusion activities can be helpful. And then ultimately helping them get good endurance and helping their new eye movement skills become more automatic. So I want to show you two of my favorite. This is a list of exercises that we just did a pilot study on, comparing eye exercises to like general OT exercises that work on vision. And as any good pilot study goes, it turned out that our study was feasible, but we didn't have the power to make any judgments. But we're hoping to be able to do a little more robust study using these exercises. It's one that we've developed here, this protocol, and we feel like it helps a lot of patients early in their rehab. And so I'm going to show you some videos of these. But then also neuromuscular reeducation techniques to help improve range of motion. It's important to note too, before I say this, we also at Craig don't do any therapy to try to improve the range of motion of an eye that has a cranial nerve injury unless the eye starts showing us that it has signs of improving. So if a person has a complete 6 palsy and it's not moving at all, or a person has a 3 palsy that it's not moving underneath and their eye is completely shut, we don't remediate until the person gets to a point in their healing where there's some movement or it shows that the eye is on its way to healing some. So I think that, you know, so we just kind of help them be comfortable until we see that the eye is showing some signs of recovery, and then we go from there. But different things that you can do to help re-educate the eyes with cranial nerve palsy would be giving proprioceptive input to the eye position. I'm going to show you that with some sensory eye stretches. You can use gravity to assist. So for example, if a person has a right outward eye turn and they're trying to bring their eye in, you could lay them on their left side and have gravity assist with going downward. You can have a person do heavy work to increase proprioception, either doing wall push-ups or pushing a heavy cart or isometric type exercise. You can leverage the quick stretch response that muscles have. And then you can also leverage reflexes. So using the vestibular ocular reflex, you can, sometimes a person, if they turn their head side to side, they'll get a little bit more range of motion than if they're just trying to move their eye cold. And that is really helpful sometimes to help give them the feel of that eye moving. And then it's important to remember that accommodation, which is the focusing ability of our eyes to focus reflexively and quickly at near and far, is reflexive with convergence. So when the eyes come in, point in, as you bring an object closer to you, our accommodative system also focuses in harder at the same time, and that allows us to have precise, clear images as things are coming to our nose. And so sometimes if you work accommodation, near, far, focusing on each eye, just with some activities that work on, you know, kind of looking at a point up close and a point farther away, sometimes that also gives a person the sense that their eyes are coming in, even though you're doing one eye at a time, and they'll do better when you start to do convergence type activities just by having a warm up of the spatial and accommodative activity. So here's a picture of a guy pushing a cart to kind of get his body more aware of where it is in midline, to get more prepared to do some convergence activities. Here are some videos of sensory eye stretches. And you'll see in the first video, the patient is having a really hard time. See his eye kind of wandering, trying to find that. And sensory eye stretches involve using a point to give a tactile feedback where you want the eye to point, and then the person pushes their eye down to find that point as hard as they can. So essentially, it's an isometric eye exercise, and you can do these in any of the angles of gaze. So you could do an up gaze, down gaze, up and in, down and out. So for cranial nerve 4 palsy, you know, we would emphasize down and in instead of down and out, because that's where they want to rest. for cranial nerve 3 palsy, we would emphasize in, up, and down. But it can be helpful to do these in any, it just gives the eye, you guys should try, I want you to try this at home sometime and just do it on one of your eyes, and you can see how different you feel proprioceptively. It's pretty remarkable. And it can even help, if you're looking to help a patient shift their weight even a little bit, doing these activities can help. And you can see the patient in the second video, he's been working on it a while and has gotten a lot better. You can see when he looks down, he's a lot more confident with where his eyes are. And so this is one of the activities we recommend for any person who's recovering from a cranial nerve issue. This can be a really nice deep cue to the eyes of where they need to go in space. Our other activity that we really like is called stick and straw, and a little stick like a dart and trying to put it in the end of the straw. This is for visual motor accuracy and spatial localization. So you see in the first video, the lady's having a hard time. And then we're going to leverage her senses a little bit here. So we're going to make the cue a little bit bigger, a little bit salient. And she's practicing here. And then in this one, she, after her practice, she's getting a lot closer to the target and is feeling a lot better about where her eye is pointed. And kind of getting that where is it thought with her eyes. Here's an example of using multisensory input. So here's a lady working on tracking, so trying to get more range of motion, and you see her, she can't abduct her eye as far as we want it to go. And so then in this, she's using her proprioceptive system to give more feedback to the eyes. So she's pushing on the therapist's hand to give a better cue of where is it. And then we're also using her vestibular sense. So we're using her vestibular and proprioceptive sense in this particular video to help her know more where is it and to look a little bit more. And then in this bottom video, she's doing pursuit again, and you see she's gotten a lot farther. But then she has an auditory cue. The therapist is tapping on the target so that she can hear where she needs to point her eye. So that's an example of using multiple senses to get the job done. And then here is another example of using proprioceptive. This patient is not only pulling with her eye, but she's also pulling with the resistive hand to give her body more input, to give her eye more input of where we want her to look. And then once a person kind of establishes, their range of motion is getting good enough for them to be able to use their eyes together, you can do any number of activities to help them converge. So one involves pencil push-ups, which is just watching a target come in. You can do red-green activities, although that's something that's really similar to traditional optometric vision therapy. And you may want to, have a collaboration with an eye doctor set up before you dabble in any of those activities. And then the Brock string is a great way for a patient to get feedback about their own convergence, because wherever they're looking on the string, it's a string with few beads, and wherever a person is looking on that string is single, and everywhere else is double, and so a person can see their own convergence. So they can learn based on the responses they're having on the string how to adjust their vision and get that accommodative convergence system a lot more refined. So that's all the material I have prepared, and I think we made it just in time for happy hour to be over, so you guys can go start your real happy hour. But are there any questions before we hang up the phone call, or quick discussion items?
This is Mark. I wanted to say thank you huge amounts for the presentation. That's exactly what these are supposed to be. Informative, reminding us of our skills, how we can apply them. how you uniquely do them, but in addition to that, some new perspectives or reminding us, such as for me, it was related to postural issues related to vision. So thank you for that. I actually don't have a question, but I have a comment. I hope it's okay to add here. I've worked with Mary Warren before, and asked her, you know, and since she created this, she's since gone on to get her PhD and written some good documentation to support it. The BIVABA that you talked about is about a $500 assessment, which may not always be doable. But she did tell me that she would be willing, if you reach out to her, to answer any questions to help problem solve as need be for your clinic. So I don't know if you've had that discussion with her, but just a little FYI for the team.
Yeah, that's so nice. Thanks, Mark.
Thank you.
Hi, Amy. This is Suzanne.
Hi, Suzanne.
Amy, I was just curious if there are any ethical considerations or for any therapists really collaborating that need to collaborate with ophthalmologists or optometrists that practitioners need to consider.
I think the big things is that definitely, I mean, it's important. I think there's enough patients in the world, you know, for us to all, you know, like it takes a village and there are lots of people who need help. So I'm a really big proponent about, you know, it's really hard for us to get in big turf things in neuro rehab because, you know, the patients need our help and we're helping a person's whole system get better. But I do think it's important to remember, especially with lenses and prisms, you know, that's way out of any therapist's scope. You know, we don't know how to diagnose or prescribe prisms or lenses. And so I think to use the Fresnel prisms and to, you know, if a person needs a pair of glasses, they need a pair of glasses and are going to need an eye doctor. But I think there are a lot of things that are within our scope in terms of helping a patient be more comfortable, like using a spot patch. And if a person if they are having double vision or ocular motor issues, you know, going ahead and kind of helping them be comfortable and start to learn how to move a little bit better. But I think always keeping that referral in mind so that we can have a collaborative approach and make sure we're not missing anything, if that makes sense. But I do think, you know, there is some room for us to be able to help patients get better. And a lot of times they can resolve things, you know, before they even, you know, get out there for their major, you know, optometry or ophthalmology. You know, we can make a lot of positive improvements while they're on a really heavy recovery trajectory. But I think, you know, we definitely have to respect the diagnostic power of the optometrists and ophthalmologists, especially with lenses and prisms. And then, you know, sometimes we just don't know, you know, they can look in the eye and tell us if there's a cranial nerve 1 issue. You know, I think continuing to push for those evaluations and then collaborate about treatment can be really helpful. But I wouldn't worry about trying to make a person more comfortable before they see an eye doctor by using patching.
Thank you.
You're welcome. Other thoughts or questions?
Hi, this is Veronica Rowe. I had a quick question. Do you have any resources that can help a clinician? I'm thinking specifically new therapists. I teach students as to where to place the patch, the partial patch. I know if there's an obvious place that the eye is tending towards, that's true. But in some cases, I know it's always been sort of trial and error. But have there been any studies done or resources that can tell you best places to put the patch for certain symptoms?
Dr. Politzer wrote an article a long time ago that could be helpful. And I feel like I found one other article, and I could see if I could dig it up, but it might take us the same amount of time to find. But honestly, trial and error really is the best, because what works most with one patient, you know, isn't going to work the same for another patient. But I always recommend starting where the eye is pointed on the affected eye and see if that makes them comfortable. I work in brain injury, and so a lot of times we have to put the tape patch over the whole lens. And then we start there often because the patient will try to look around it, or their attention isn't good enough to like really make sense of that. So when we just cover the whole lens, that takes care of whenever they move their head in all the different directions, and that tends to help. But there are certain people whose affected eye are their more dominant eye, and in that case, sometimes they feel a lot better having the other eye patched, or if there's an acuity issue in one eye. So maybe their unaffected eye has horrible acuity, but their affected eye has great acuity, and so we cover that. So it really is whatever makes the patient more comfortable.
Great, thank you.
You're welcome. Cool. Well, I really enjoyed speaking with you all today, and I'll try to find out from Mark and Cecile what's the best way to share this presentation.